Hi, my name is Claire Ranns. I'm a diabetes specialist pharmacist for the ICB, and with me today I've got Dr. Mark Wright, one of our consultant nephrologists at the Leeds Teaching Hospital, and he's chair of the Yorkshire and Humber Kidney Network. So welcome to part 2 of your CKD target session. The first session was delivered in September by Mark and Alice, one of our PCN pharmacists, and the focus of that session was on primary care management of CKD. Today, we're going to focus on more advanced CKD and some of the feedback and queries that we've had through our GPOP, General Practice Outcomes Programme Incentive Scheme, and some of the advice and guidance and referrals that Mark sees into his team. So I'll give an overview of GPOP update and data so far, and then Mark will talk about when to refer to renal and in particular focusing on patients with frailty and CKD. I'll give a brief overview to GPOP 26-27, and then I'll pass you back to Mark, who's going to talk through the management of advanced CKD. So why are we focusing on CKD? Well, we know that CKD has got a big impact in West Yorkshire's healthcare system, from the patients that you manage in primary care right through to the patients who are receiving dialysis for end-stage kidney disease. CKD also increases the risk of cardiovascular disease, so that cardiovascular risk is important, and slowing renal decline, and that was the focus of your first session at Target last year. So we're focusing on getting blood pressure to target below 130/80 or lower, depending on the urine ACR level, using optimal therapy, ACE inhibitors and angiotensin receptor blocker drugs. The next step is addition of SGLT2 inhibitors, which are very effective treatments, and then considering finerenone for people with diabetic kidney disease. And finally, don't forget atorvastatin 20 to help reduce that cardiovascular risk reduction, and we should be considering that for all patients. At the bottom of the slide, there's links to all the guidance across West Yorkshire, our CKD guidance, and all of these links are available on the CKD template, which is available in System 1 and EMIS. So I'll just recap what we're covering in GPOP CKD indicators this year. So there's 3 elements to increase the detection, the coding and the treatment of CKD. So looking at that increase in detection of CKD, we're focusing on that hypertension cohort because they're at really high risk of developing CKD. And we know that by screening them using a urine ACR level, will help to detect kidney disease early on so that we can slow that decline of the renal function. Each practice has been set a target of achieving above 5% more than their baseline level. The second aspect, so increased coding using CDRC searches, which are very precise searches and revealing a wider cohort of patients that the CQC searches are finding. So we've had feedback that these are really good, robust searches. And then looking at the treatment, we're aiming to increase the percentage of people on RAS therapy titrated to maximum tolerated dose, and 2 and 3 are combined for your practice, the targets combined for you to achieve a 70% of your allocated patient cohort for review. So first looking at the percentage of people with urine ACR testing, we can see a nice steady increase from 38% across to 45% of the Leeds average. So we've achieved above that 5% target that we've set. When we look at individual practice breakdown, however, we can see a wide range. So some practices haven't improved, whereas some have achieved 45%, which is fantastic. So that's really showing what work can be done. And I know that you've shared a lot of your innovative ideas of how you've managed to get people in for urine ACR testing, and we've shared that at previous Prescribing Leeds meetings and other forums. When we look at the next group, the coding and the treatment to target group, there is a slower increase across the Leeds average. We're not quite hitting that 70%, but there is time to achieve that. We've got till the end of the financial year. We really want to see that shift and that move towards that 70% target. We've looked at individual practice breakdown, and we can see there's a bigger variation here. We've got between 0% and almost 300% attainment of that target. So we can see that people are really getting behind this CKD GPOP work and making big changes, which really makes a difference for people living with CKD. Most importantly, as a result of all the coding, we've increased our prevalence from around 3.3% up to 4%, which is a fantastic result because Leeds was lagging behind the West Yorkshire and the national average. So as an ICB, we've made some fantastic progress. When we look at the individual practices, we can see that 16 practices are achieving that target of 70%. However, there's some practices, there's around 20 that are below 15, and then some in the middle. So what we'd like to see by the end of the year is everyone move into the right-hand side of this bar chart and hitting that 70% target. So if you're not sure where you're at with your data, it's available on the PQI dashboard, which is the Primary Care Quality Improvement Dashboard, or your ICB linked pharmacist or technician can get that data for you. I'm now going to pass you over to Mark, who's going to talk about the renal referral criteria.
Thanks, Claire. It's great to hear about the progress that we're making in Leeds with CKD management, partly down to GPOP, but also down to people who are really buying into this now and understanding the need to build CKD care into their normal working week. Some things have cropped up through the GPOP period and before, really, and those are things about referral to hospital services, renal referral. So the referral criteria are there on the screen for you. They haven't changed. The top one relates to the kidney failure risk equation now. So if you have a 5-year risk of developing stage 5 CKD that is greater than 5%, it says refer to kidney services. Generally, that's really good. But I just want to draw your attention to the top line on the slide. And that says refer people considering their wishes and comorbidities. And that's important because frailty and CKD are often linked. The slide that you have now shows the proportion of different age groups with CKD. It's no surprise to see that it's more common as we get older. We all lose around 0.5% to 1% of our kidney function each year that we're alive after the age of 40. So by the time you get into your 80s, 25% of people have got CKD. And we also know that CKD patients are the most comorbid individuals on your lists. They have on average more than 3 long-term conditions. So if you're in your 80s with CKD, hypertension, diabetes, quite probably heart failure as well, your insides are not going to be in a very good shape. One of my colleagues, Andrew Mooney, has been looking at the low clearance clinic that's been running in Leeds for over 20 years now. And that's where we see people largely in order to prepare them for kidney replacement treatments like dialysis. And he finds that over 80s in that clinic typically don't make it to kidney replacement treatment. Over 84% of them die before reaching that point from their other comorbidities, which does prompt us to ask the question of maybe there are better ways of managing things for those people. It also begs the question, what's the purpose of referral? So we have lists of when to refer, but why? Why we're referring? Well, I'm going to really simplify things here, which is always a bit dangerous. But when I'm looking at a referral, the first thing I'm thinking about is this standard CKD? Is it hypertension, diabetes stuff? Because if it is, then I don't have any treatments that aren't available to primary care. Blood pressure, ACE/ARB, SGLT2 inhibitor, finerenone for diabetes, GLP-1 agonists, possibly. What I'm asking myself is there a different thing going on here? Is there an inflammatory condition in the kidney? Is there something that has a specific treatment that needs a diagnosis that we can treat? Which really means, am I going to do a kidney biopsy on this person? I need to see the urine dip to know that. Kidney biopsies are invasive procedures that carry risk. Is this person going to be fit enough to go through that procedure? Are they going to understand the consenting process? If they have an inflammatory condition and we're going to treat it, it's going to be immunosuppression, typically quite heavy stuff. Are they going to be fit enough for that? If you're in your 80s, that may not be a great idea. And the other thing we do in hospital services is prepare people for kidney replacement treatments, as I mentioned before. So if we think about those, we think about dialysis. What's that like if you're a 80-year-old frail individual? Well, people do quality of life scores for all sorts of long-term conditions. And when they do scores in dialysis populations, you find that the average results are similar to people who have paraplegia. What does that mean? Well, it's a bit hard for us to perceive what life on dialysis is like if we don't live with it. But we can get a bit of an idea about paraplegia. You know, those people typically can't get dressed themselves, typically need help with that. They're doubly incontinent. So that doesn't sound very appealing, doesn't sound great. So why are dialysis scores like that? Well, dialysis is really time consuming. You know, roughly half your life is spent doing the treatment that you need in order to stay alive. And even when you're not doing the dialysis or travelling to the dialysis unit, you're still restricted in terms of what you can eat. You're constrained in terms of having holidays, going away from home, meeting people, attending family events. It's difficult. It's also physically really abnormal. So a lot of people doing dialysis will have symptoms. They won't feel great. But if you're old and frail, and you think about those quality of life scores, if they're not great to start with, they're not likely to get better with dialysis. You know, we can alleviate uremic symptoms, but we can cause many, many other symptoms with that form of treatment. What about a kidney transplant? That's a great idea, isn't it? Well, it's true, you know, kidney transplants do give better quality of life, more freedom, more flexibility once you get past that first 3-month period. But if you're old and frail, you're not going to get one. There are 800 people getting dialysis through the Leeds service. Only about 20% of them are on the kidney transplant waiting list because organs are in short supply, the operation carries risk, and the immunosuppression that they take carries risk. So it's not unheard of for us to transplant someone who's over 80, but it's really, really rare for us to do that. So that moves on to supportive treatment, which really means taking tablets, maybe an injection once a month to treat your anemia. So this can alleviate some symptoms, rebalance some aspects of the body that are disrupted by kidney failure. Big advantage is it is much less intrusive, much less time consuming. The downside is you may not live for quite as long. So it's not a great option if you're 40 with a young family. But if you're 80, your mobility is not very good, you're tired, your favourite pastime is having a nap, this seems like a pretty good option to me. So what we're asking is that when referring, think about someone's 5-year survival probability as well as their KFRE 5-year risk of developing stage 5 CKD. Because if survival probability is not great, the KFRE risk is less important really. And again, just think about those aspects as well in terms of fitness for invasive procedures and heavy treatments. Think about what dialysis will feel like if you're thinking, well, this person might benefit from dialysis. Just think about what it will feel like for that individual before making that referral. And with that, I'll hand back to Claire, who's going to talk about what we hope will happen next year in the next phase of GPOP.
Thank you, Mark. So the Medicines Optimisation team are just looking through that GPOP data, and we're trying to look at what we might put in next year's GPOP. So we're just starting to plan how we might reshape and form some of the GPOP. When we look at our West Yorkshire CKD guideline, there's 4 distinct treatment steps. So the first step is maximising RAS blockade and optimising lipid lowering. So for GPOP 26-27, we're considering moving the focus on to step 2, so that's initiation of an SGLT2 inhibitor. Focusing first line on dapagliflozin because that's available generically. The price has fallen further this month. The tablets now are £7.22 and a fifth of that original price, so there is predictions that the price will lower even more, so there's no barriers to initiating therapy. We know that SGLT2 inhibitors are very safe and effective treatments for CKD. There's a wide range of international trials showing the evidence base for using them. If we have a look at the relative risk reduction and that line of nil effect, the SGLT2 inhibitors all lie to the left-hand side, showing a beneficial effect on that relative risk reduction of kidney outcomes. And that's across the board in people with diabetes and without diabetes. So for GPOP 26-27, it's going to look very much like GPOP this year. There's going to be the same 3 elements. The only difference is the treatment element is focused on an SGLT2 inhibitors rather than angiotensin receptor blockers. When we look at the screening element and hypertension, we've made fantastic progress and we want to build on that. So the target next year will be possibly to increase by another 5%. We're still working through our targets, but if you're already achieving a high percentage, there'll be an element of maintaining at that great level that you're at. In terms of the other two, we'll look at combining those again, because we're always going to have some coding to do as new patients are screened and fall into that group, so it's important we keep on top of that work, and then we'll focus our treatment arm onto the SGLT2 inhibitors. Again, the target will be based on your list size, and the targets are still being determined. Once it's all finalised and agreed with our partners, we will promote the GPOP, and you'll hear all the information and the detail through the normal medicines optimisation and the GPOP routes. I'm now going to hand you back to Mark, who's going to cover the management of advanced CKD. Thank you.
Thanks, Claire. So for the last part of the talk, we're going to talk about some aspects of managing advanced CKD. And the reason for this is that sometimes the things we ask you to do, the things we ask you to prescribe or not prescribe, may seem a bit counterintuitive, may be contrary to national advice that applies to the general population. Sometimes we get queries coming through. Sometimes we ask you to prescribe weird drugs. We just thought we'd try and explain a little bit about why we do that. So the first thing we wanted to talk about was atrial fibrillation in dialysis patients. So we all know there is a national push to provide blood thinners to as many people with atrial fibrillation as possible to reduce the risk of stroke and embolic disease. The problem is that there really isn't any great evidence that that approach is beneficial for people on dialysis. And there are two links here on the screen to some guidelines that have been produced by the UK Kidney Association just recently. They are really well-written guidelines, and I would suggest that you give them a little bit of time, particularly the one relating to AF. Maybe give it 15 minutes, and it just helps you to understand the sort of uncertainty about the best thing to do for this group of people. If we did want to anticoagulate, previously our only option really was warfarin, which we all know is a problematic drug. And in people with kidney failure, it has some specific and really unpleasant side effects, which I will elaborate on shortly. But this guidance talks about DOAC-type drugs like apixaban. So they aren't licensed for use in people with very bad kidney function in the UK. Apixaban is licensed for that use in the US, though, and in other countries. These guidelines describe the published data on the use of apixaban in people on dialysis these days, and it's building up. And the safety profile in terms of bleed risk seems to be comparable or probably slightly better than warfarin. So you may find that we are starting to recommend apixaban 2.5 milligrams twice a day for dialysis patients. If you get a trigger asking you to anticoagulate one of these people, please check our clinic letters and see if we've had a discussion with the patient about it, see what recommendation we've made. If we haven't made one, please drop us an advice and guidance before starting anticoagulation. Next question is, why do you prescribe cholecalciferol? Because we're not supposed to do that. Well, the reason we prescribe it is because the NICE CKD guideline says that you should give it to people with a GFR less than 30 and vitamin D deficiency. And we know, because we measure vitamin D levels in people, that if you use the conventional replacement strategy of high dose weekly treatment for 7 weeks, you'll correct deficiency, but then levels will drop and you'll be back in the same situation again. We also know that giving a low daily dose or alternate day dose gives a more sustained, stable vitamin D level over the longer term. So that's why we ask people to prescribe it with their other drugs. These people are often on many tablets, don't always have a great relationship with tablets, so getting it from one supply point is better than asking them to buy it over the counter. So I can hear people all around Leeds going, what? The ICB tell us not to supply this stuff. And sure enough, there is the commissioning guidance on the screen. NHS West Yorkshire does not support the prescribing of vitamin D. But the next line are the exceptions to that. And they include people with medically diagnosed deficiency, which will be the people we've measured vitamin D levels on, and people with lifelong or chronic conditions like those with stage 4 and 5 CKD. So we're here to say the ICB absolutely does support the prescribing of cholecalciferol for these patient groups. And that brings us on to CKD mineral bone disease, because that's really what this sits behind. So this is really complicated, so I'm going to try and skim the surface and just explain a bit about why we ask you to prescribe these medicines, often which are amber category drugs. If your kidneys don't work, your bones have some problems. They end up in a high turnover state and a demineralised state. So you have quite a high fracture risk, which is bad. But the flip side of that is that calcium and phosphate that should be going into your bones ends up going into your blood vessels, which is really bad news. That's a really unpleasant, aggressive atherosclerotic process. So there are some horror photos on the screen here. On the left, we see a calcified coronary artery on a CT scan. That foot X-ray on the right is quite abnormal. Between the big toe and the second toe, you'll see another bone has appeared. Well, that's the patient's artery. And the fourth toe has that fluffy cloud appearance on it. Well, that's calcium and phosphate deposition in the tissues and the skin. And what that turns into is that awful photograph beneath. That's the worst thing that I deal with in my job. We call that calciphylaxis. It's painful, it's degrading. That's months in hospital with a high probability of death at the end of it. So when we're treating mineral bone disease, that's what we're trying to prevent. Why does it happen? You know, it would take me a day to explain it properly, so I'm going to go very, very simple. Basically, it's deficiency of vitamin D, particularly active vitamin D, causing increased activity of the parathyroid glands, increased bone turnover. It's problems excreting phosphate. So you end up with this mix of lots of phosphate in the blood and these hormones, and there are various growth factors like that FGF growth factor present in high levels for these people. And that triggers a process that causes the calcification of the blood vessels. That calcification process is inhibited by vitamin K. Most of these people tend to be vitamin K deficient because they tend to not eat very well. And I'm just going to take you back to warfarin now. Warfarin, of course, is a vitamin K antagonist. So if we give a vitamin K antagonist to people who are vitamin K deficient already, with this going on, we will really take the brakes off that process and drive that vascular calcification further forward. So that's why we really don't like using warfarin for people on dialysis, although sometimes we have to. So what do we do about it? Well, we correct vitamin D, as described, initially with cholecalciferol. And if we don't get the results we want, then we use activated vitamin D, alpha-calcidol. So that's in addition to cholecalciferol. We do everything we can to keep the phosphate down, phosphate. Start off by telling people to avoid foods and drinks that are rich in phosphate. If that doesn't work, then we give them some tablets to bind phosphate in their bowels and stop them absorbing it into their bloodstream. Some of those contain calcium if we want to increase the calcium levels, and others are calcium free if we want to bring them down. Those latter ones are savellamyl carbonate, lanthanum carbonate, and sucroferric oxyhydroxide, which is the most potent of the phosphate binders. Sometimes that parathyroid overactivity reaches the point where the gland escapes from normal regulators. So then you'll find high calcium levels and high parathyroid hormone levels. In that situation, we use cinacalcet, which is a drug that can often pull the parathyroids back in line. So that is a brief romp through renal bone disease and its implications. So I'll just close off now with a summary of what we just discussed today. We talked about GPOP CKD. We saw what great progress we're making across the city. And we talked on what we want to do next year and push the rollout of SGLT2 inhibitors. Really powerful medicines. I think this is a real step change, not just in CKD, but in cardiovascular disease management. We talked about the West Yorkshire CKD guidance and the templates that are there in System 1 and EMIS to help you just make this normal working business. We talked about frailty and life expectancy and thinking about those things when we're looking at referral or not referral. We spoke about AF in people on dialysis and said, please don't automatically anticoagulate, please check their clinic letters, send us an advice and guidance if we haven't specified what we think is right for this individual. And we talked about cholecalciferol and how it absolutely is appropriate to prescribe it for people with stage 4 and 5 CKD. So we have a couple of slides at the end with various resource links for you, and then we'll close off with our contact details. We hope you found this useful. Feel free to get in touch if we've raised any questions that you want some clarification about. Thank you very much.